So much for, thank you guys so much for having us. We're excited to talk about this topic, and I'll kind of explain a little bit about who we are and kind of our practice. I'm going to go ahead and share our screen. Give me 2 seconds here. And someone give me just a quick shout out that everything looks good.
Yes, great.
Yep. Thank you. All right. My name's Laura Douglas. I'm a physician at University of Chicago with Insia Patenwala. We both, within OBGYN specifically, we both did our residency in obstetrics and gynecology. And then we both did additional training in fellowship with minimally invasive surgery. And kind of within that fellowship time, we do kind of share an academic and practice interest in endometriosis in pelvic pain as well. So we're excited to talk about the topic that we love to talk to our patients about.
Laura, I think we are in presenter view is being shown to everybody.
Oh, yep. Okay, hang on one. Thank you so much.
No problem.
Let me start there and see it. Does that look better?
Yes, that looks perfect.
Okay, thank you. I thought you not perfect. Okay, sorry about that, guys. We have nothing to disclose tonight. So looking at what we want to accomplish in this short time is understand a little bit more of the pathophysiology. It's a very complex disease, and we'll do our best to try to kind of break that down into bite-sized manageable pieces. Symptoms, a lot to talk about on that end, and how we manage this disease process, both from a medical and surgical standpoint. Recurrence, we'll touch on that a little bit, as well as chronic pelvic pain symptoms. And then we also, have a little bit on PCOS at the end, just to kind of tie everything together. Before we can kind of dive into how to start managing and what endometriosis is, let's kind of look at the definition of how we define what this disease process is. And endometriosis is endometrial-like glands or stroma that are outside the uterine cavity. So hopefully you can see maybe my arrow, or if not, the picture towards the right, you're going to see the uterus. So this is kind of a cross-section of what the human body looks like from a pelvic standpoint. The uterus is the muscle, kind of the muscle organ right in here with the thicker walls, and then that black space is on the inside. So it's a hollow organ. We kind of know that because our endometrial cells and menstrual blood come from the inside of the uterus. Endometrial cells are supposed to be found on the inside, but any of these other kind of blue dotted areas, this is very abnormal. When those type of cells are on the outside, they can cause a whole host of problems and symptoms. It's polygenetic. So we know that we're understanding more that there's a genetic predisposition. So we see that patients who have endometriosis, oftentimes, if you dig into their family history, moms, aunts, grandmothers will start to see more family history of this type of diagnosis too. And there's several factors that come into play. There's more obviously than is straightforward with this disease process, and we'll try to touch on some of those nuances in a little bit. How people get this disease, it's complicated. That's the simplest way I can say it. We have several theories that I'll go over of what we think is happening, but really, truly, there's not a perfect connection from point A to point B yet with this disease process. We are understanding more and more that the immune system and a lot of biological factors that occur within the pelvic microbiome probably play a big role into why some people develop this and not others. Endometriosis as a disease, 15, 20 years ago, when we were treating this disease process, we were kind of treating all patients as the same and the disease process the same. But we know that this disease is broken down into a couple different subtypes, which I think really the more we understand the differences in the subtypes, hopefully we'll get better, kind of more targeted treatments. The disease can be located anywhere. It's highly variable with the clinical presentation. So I always tell my patients, no two patients are the same. We have patients who have an incredible amount of disease burden with very minimal symptoms, and we can have patients who have minimal disease burden with significant symptoms. So there's probably underlying things there that we have yet to kind of understand about this disease. And we can all agree, though, it can be very challenging to diagnose and to treat. So looking at the pathophysiology, there's three kind of mainstay theories to why we think endometriosis develops into what areas. So coelomic metaplasia just means that within the abdominal or pelvic cavity, that the peritoneum, which is a very thin layer of tissue that I think of it as the body's wrapping paper that kind of coats your organs and your insides, that cells under environmental influence transition and they change to these endometriosis areas. We do see that endometriosis in patients can be in your lymph nodes and can travel up your lymphatics to distant areas from the pelvis, and also through the bloodstream. The most common one that most people ascribe to is the retrograde menstruation. You guys have probably heard about. So that means that during a period where blood is supposed to exit the body through the cervix, it sort of works the opposite way and comes out the tube. And as blood accumulates there's other factors, again, the immune system, a person-specific microbiome, that these cells or debris don't get cleared out. They kind of start to invade into that area. And there's these feedback mechanisms that happen where these islands or these lesions kind of stick and they take hold and continue to develop. Most likely with emerging research, we're going to understand a little bit how all these three theories kind of interplay together, because there's likely truth in all of them because of the disease spectrum that we're seeing. But this is the most kind of simplified way we can think about it. The prevalence is between 6 to 10% of reproductive age patients, and I think both Incy and I can agree that this is probably an underrepresented number. It's a challenging diagnosis, though. I think there's a lot of patients who are symptomatic out there who have this disease that we just don't know about. It's present in about 20 to 50% of women with infertility. So we do know that it can cause problems in that reproductive lifespan as far as creating infertility or subfertility. So the proportion of patients who are seeking fertility treatment, there's a large proportion of those patients, obviously, with the fertility issue. It's the leading cause of secondary dysmenorrhea, or what we consider to be painful periods. So I kind of mentioned a little bit thinking of endometriosis now as a disease on a spectrum. There's three kind of categories or subtypes that we're gonna talk about, and I'll touch on those in a little bit further. But there's endometriosis that's affecting the ovaries. So that's commonly the area where we can pick up most readily on imaging or like ultrasound. They're going to form cysts. So it's kind of aggregated areas of endometriosis, and it forms, kind of a balloon on top of the ovary. So we call that the ovarian subtype. There's also peritoneal subtype. Again, that peritoneum is the body's wrapping paper, that thin layer of tissue. The yellow areas there is just a schematic to represent a peritoneal subtype, where it doesn't get very thick but it's sort of over on top. And I describe peritoneal endometriosis as a lot of times thinking about if you put a paintbrush inside a paint can of kind of clear white paint and you flick it, there's kind of this like smattering that happens, and it doesn't go deep. It's kind of right on the surface, but it really kind of affects quite a bit of that tissue down by the pelvic organ. And so that's how I kind of explain that the peritoneal subtype. And then we have what we call deep infiltrating endometriosis, or DIE. Those are areas that if you've ever gone down a Google pathway of what is endometriosis, they're going to show you a lot of pictures, which we'll look at here in a few minutes, of kind of these purplish lesions. They're macroscopic. You can see them. I can see them. We can all agree that they're there. that's deep infiltrative endometriosis. And those areas are a large part of what starts to cause, it invades more than about 5 millimeters into the peritoneum. So it starts to invade and touch other organs and cause a lot of scarring too, because it's bringing organs that should normally have some space in between them and causes them to kind of stick together. Almost like sometimes you pour a little bit of cement or glue somewhere and two things now start to become one. A lot of symptoms can be contributed to endometriosis. Pelvic pain is a big one. Pain at the time of periods or dysmenorrhea. Patients who, tell me that they've had painful periods since the beginning of when their period started, and they would miss school or they miss work because of how painful it is. I can almost assuredly tell them that they most likely have endometriosis, just hearing those two things of painful periods and missing school. Now, we know not every patient falls in that neat category, but that's very abnormal, and oftentimes they're told that's normal for a good number of years. Pain with intercourse, it can also be a sign that something's not quite right, that there's unusual to have pain or there's something going on. The bladder and bowel can get involved at times too, or just from general inflammation. If there's any issues with getting pregnant, right? We talked about the subfertility and infertility problems that it can cause. There's a lot of fatigue from having this, low back pain. And we also know that, surprisingly, at times this disease process could be asymptomatic in patients as well. And just to touch on a little bit more, in a lot of our younger patients, when they have a diagnosis or a newly diagnosis of endometriosis, sort of the first concerns or questions they always ask about is their fertility state. And, why does endometriosis cause problems with getting pregnant? There's a couple different avenues of where these issues arise, and some patients can have problems with a few of them, and others it's all of them in combination. If you think about endometriosis as a very kind of inflammatory disease process, right? So general inflammation can impact the health of your pelvic organs. They can also, over time, unless it's treated properly, that it can decrease the quality of the egg. So, you have your cohort of eggs that are on the ovaries, and over time that chronic and consistent inflammation can cause issues, especially if you have ovarian subtype. That's a lot of inflammation in endometriosis, specifically where those oocytes or those eggs are in the body. Inflammation, again, can impact how early embryos develop. So if there's a lot going on or a lot of backtracking into the uterus with inflammation, that can impact the environment of an early pregnancy taking hold and progressing normally. The fallopian tubes, right, they can be affected just like anywhere else in the body, and the fallopian tubes that are essential for having an open communication from the ovaries to the inside of the uterus, that channel or that passageway, if that's being impacted with endometriosis or inflammation, that's going to obviously be a big factor in fertility. Patients who, I always tell them if they're being treated and we have a good plan for them, and we catch it as early as we can and we know about it, the earlier that we can intervene and treat. I have a lot of patients who really do well from a fertility perspective, as long as we have a good management plan in place. So it's not all doom and gloom if this is your diagnosis. I think it's always so important to know about it, because there's things that we can do to kind of improve the fertility landscape. Okay, I'm going to hand it over to Anthea.
Okay, thank you everybody for having us. So Laura and I are just going to kind of switch back and forth discussing different parts of this presentation. For the next area, we are going to be talking about evaluation and medical management. So in general, when someone comes to see us in the clinic, of course, we get a very detailed history and things that really signal to us that this might be endometriosis are, some of the following, and some of these Dr. Douglas already touched on, but those include really an early age at the time of their first period. So if someone had their period between like the ages of 9 to 11 years old, then we are, a little bit more worried about endometriosis. In general, a lot of women will have shorter time periods between their period. So instead of that typical, 28-day cycle, then they will oftentimes have, like a 21 to 24-day cycle. Also, heavy bleeding is oftentimes associated with endometriosis and adenomyosis. And then, of course, painful periods. Laura just talked about infertility, so I'm not going to go into too much more detail about that. But of course, if they have a family history of endometriosis, then we do, always take that into account. And then, of course, the main concern is always usually pain. So the pain can be cyclical or constant. Oftentimes we'll get a history that, they started having really painful periods kind of right off the bat within the first 6 months of starting their periods as a teenager. And then that pain became progressively worse and worse. And then they started having pain even when they were not on their period. And so in general, that pain progression can start to include other kind of organs as well. And so we will, get history about, what their bowel movements are like, including, a lot of patients will have pain with bowel movements, or they'll say that they have blood in their stool, or especially when they're on their period, they feel like they have to go to the bathroom a lot, whether that is urination or having a bowel movement. Some women will also have endometriosis affecting their bladder, and so they'll see blood in their urine or urgency when they are on their period. And then, of course, someone will unfortunately also have pain with intercourse, and that usually signals to us that sometimes there is some endometriosis in between the uterus and the rectum, or affecting the rectum itself. So in general, we typically will do an exam at the time of initial consult. That will almost always include an abdominal exam. Now, we usually like to do a pelvic exam, but of course, a lot of it depends on the patient comfort. Now, some patients have been in so much pain for so long that they have trouble tolerating a pelvic exam. If we are dealing, with an adolescent patient, then, we don't necessarily always need to do an exam. The speculum exam is really the least important part of the exam because it's very rare to see cervical or vaginal lesions. That's usually really, really high grade endometriosis, and we see that maybe in less than 5% of patients. We do usually like to do like a single digit vaginal exam to feel kind of whether the uterus moves, because if it's fixed in place, that usually means that there's a lot of scar tissue or endometriosis around. And then also to see if there's any nodularity that we feel, because in general, that can be something that contributes to pain with intercourse. And then we also want to see if we can feel the ovaries and whether they feel enlarged at all, to see if there are ovarian cysts that could be associated with endometriosis present. And so these are just some pictures of endometriosis in odd locations. So usually we see endometriosis inside of the pelvis, but every once in a while we can see it, in outside of the pelvis as well. So that picture up top is actually endometriosis in the belly button that occurred after a scar from a previous surgery. And so sometimes if there's spillage of endometrial tissue during previous procedures, it can seed in the tissue that is beneath the skin. And that's actually what we see in that next picture for a patient who underwent a C-section, and then they end up forming a collection of endometriosis cells underneath their C-section scar. And then that picture at the bottom, it's a little bit harder to see, but that is actually of the inside of the vagina where there is a lesion of endometriosis underneath the cervix, and that is, causing vaginal bleeding and pain with intercourse. Now, in general, whenever someone comes to see us for pelvic pain or abnormal bleeding, we almost always get a pelvic ultrasound. Typically, we get the best images if we are able to do a transvaginal ultrasound, which means that it's a probe that's inside of the vagina. And so it can more directly view the uterus. If, a patient cannot tolerate that, then we can do abdominal ultrasound, but sometimes it's harder to see everything that we need to, and the bowel can sometimes get in the way of being able to visualize the ovaries. But these pictures that are kind of surrounding the slide, you can see that in that top picture, that is essentially kind of very characteristic of what we call an endometrioma, which is essentially a blood-filled cyst, consistent with old blood. That is what we see with endometriosis and endometriomas. And then these other pictures show endometriosis in different locations. One is near the bladder, another one is near kind of that what we call the rectovaginal septum, in between the uterus and the rectum, and then another one is like a rectal nodule. As far as other imaging, so in general, we don't have any great imaging studies or lab studies that are very specific for endometriosis. Now, if you look at kind of studies that are published in the literature, a lot of them come from Italy, where they have a very strong ultrasound program where, they do rectal ultrasound in addition to vaginal ultrasound. And so their ultrasound can be a little bit more accurate in detecting endometriosis. But in general, the standard for ultrasonography in the United States, it is very hard to detect endometriosis unless there's a large obvious lesion. And as Laura discussed before, a lot of endometriosis is small superficial lesions. And so those are very hard to detect with really any imaging study. A lot of times we will order an MRI, depending on how severe a patient's symptoms are, to see if, they have deep infiltrating endometriosis in areas that the ultrasound is unable to pick up. But even MRI is not perfect, especially for the superficial lesions. And then if a patient, comes to see me and they have severe pain with bowel movements that seems to be worsened by their periods, or they're having blood in their stool while they're on their periods, then I will usually refer them to a gastroenterologist or a colorectal surgeon to complete a colonoscopy to make sure they don't have endometriosis implants that are invading the rectum. So, about 15, 20 years ago, almost everybody where we suspected endometriosis would undergo what we call a diagnostic laparoscopy to determine if they truly have endometriosis. But now, over time, we've realized that we don't have to actually make sure someone has endometriosis before we can start them on medical treatment. So we don't necessarily have to jump to surgery right away. We can actually use hormonal treatment to see if that improves symptoms. And we know almost all of our hormonal contraception will typically will decrease symptoms and also decrease progression of disease. And so in general, a lot of people, the first thing that they are started on, whether their symptoms appear as when they're teenagers or young adults, in general, the most common approach by many gynecologists is the birth control pill, because it's widely available and widely tolerated. But you can start with other forms of hormonal birth control. In general, most birth control pills have a combination of both estrogen and progesterone. We know that estrogen can actually stimulate endometriosis. So a lot of us like to avoid estrogen if we can. But if patients really want regular monthly periods, if that's something that's important to them, then we can start them on birth control pills. But we still usually try to do something that is more continuous rather than cyclical, because what triggers the pain is a lot of times that change in hormone levels. And if we can keep your hormone levels at a steady state, a lot of times that controls the pain. But really the best medications to help with endometriosis are things that will stop your periods altogether. And those include high dose progesterones. And so in general, we have different options for those. one of the popular progesterones that unfortunately is not available in the United States is Dynogest. In the US, it just recently, a few years ago, became available, but it's only available as a combined birth control pill with estrogen. And that the name of that medication is Natasha. So it is something that people can request. However, it is not always covered by insurance first line. Other medications that we often use are norethindrone acetate. The most common formulation of that is called Agestin, and we can prescribe it anywhere between 5 to 20 milligrams daily. Now, there is even a smaller dose for patients who are really worried about kind of side effects from hormones or are very sensitive to hormones, and that medication is called Micronor, and it's essentially what we would consider like a baby dose. It's 35 micrograms, but in general, that's a progesterone only medication that can decrease bleeding from periods and decrease pain. The other, common medication that people will hear about is Provera, which is also called medroxyprogesterone acetate. And once again, that can be dosed 5 to 20 milligrams daily. In general, both of those are pills. Then there is the Depo shot, which is intramuscular injection that women get every 3 months. In general, it is very effective at stopping periods. A lot of women will have irregular bleeding, but I would say most women have irregular bleeding after that first injection, and then after the second injection, a lot of women will just stop having periods while they are on it. The main concern with Depo is that while it's very effective at stopping periods and decreasing pain, it does have a significant side effect of weight gain. Not every woman will gain weight, but many do. Out of all of our birth control options, it's the one that's most associated with weight gain. And so that is why many people choose not to use it. It also can adversely affect bone health, but we usually see that more in patients who have prolonged use after 10 years. And then what is very popular are the IUDs. So the levonorgestrel IUDs have a small dose of progesterone in them. We have multiple different kinds. The most popular one and the one that is most widely known about is the Mirena IUD that lasts for 8 years. And this is a small intrauterine device that locally acts on the uterus. It has less systemic absorption than the other medications. And so that usually translates to fewer side effects. It can cause abnormal uterine bleeding patterns, but typically it'll make periods lighter or stop altogether. The Liletta is essentially a generic version of the Mirena IUD. And then Skyla and Kylena are very similar to the Mirena IUD. They're just last for shorter periods of time. So Skyla lasts for 3 years, the Kylena lasts for 5 years. But all of these IUDs, if someone wanted to become pregnant, we can pull them out at any time, and their fertility usually will return back to normal within 6 months. And then kind of the next class of medications are called gonadotropin releasing hormone agonists and antagonists. Essentially, all of these medications will put patients into a temporary menopause. And so that means that people will have menopausal symptoms. Now, some symptoms are more severe than others, but when we are thinking about menopausal symptoms, we're mainly thinking about hot flashes, mood swings, vaginal dryness, bone aches. Now, some women will love these medications and some women will hate these medications, but in general, they are very effective at stopping periods. And then also they not only will decrease disease progression, they can also cause disease to go away. And so in general, kind of the main medications that are available. So there's naproxen acetate. Now in practice, this is used very infrequently because it's very expensive and most insurances do not cover it. I personally have actually never prescribed that medication. Now, Lupron is very popular. Has been along for a very long time, over 20 years. It's also called depolipurolide acetate, and you can get either a 1-month injection or a 3-month injection. And typically you can stay on it for up to a year. At the 6-month mark, we oftentimes will give a little bit of hormone back, meaning we'll put you on a progesterone to help, decrease risk to the bone, to bone health. But in general, if it's well tolerated, patients usually stay on it for a year. Goserelin is similar. It is a subcutaneous implant injection that is given on a monthly basis. And that is really, it just depends on kind of formulary for your hospital, whether you can get Lupron or Goserelin. Now, the newer medications on the market are Elagolix and Relugolix. So Elagolix is Orlissa, and then there's a combined version where it's combined with estrogen and progesterone, which is called Orion. These are tablets. So instead of having an injection that, is going to last in your body for a month or 3 months, you have a little more control over these. So if you really don't like the side effects, you can stop more quickly than you can with, some of the other options. But in general, Orlissa will still cause, similar side effects such as, the hot flashes, mood swings. Orion and Myfembree, since they are combined with estrogen and progesterone, the thought is that they will cause fewer side effects because they're giving you back a little bit of your hormones. And so you're not in as much of a menopausal state. And then, of course, there are non-hormonal medications that we can use to treat pain. And those include, kind of our, run-of-the-mill things but they do work. Those include ibuprofen, naproxen, which, is very, similar to Aleve, celecoxib, mefenamic acid. These are all what we call non-steroidal anti-inflammatory drugs. And in general, they target a lot of the prostaglandins and things that trigger a lot of pain. Okay. And now I'm going to hand it back to Laura.
All right. I think, okay, yep, I'm off of mute again. All right, so we're going to switch and transition now that we kind of talked about some of the medical management. We'll dive back into to surgery and some of those considerations. I think a couple of things to consider, when we have patients with surgery in general, most patients at this point in their endometriosis journey have already tried 1 or 2 front lines of medication and either are inadequately treated or having recurrence or pain that is not adequately treated. We really do want to move to more, not just treatment fees, but kind of to understand maybe why they're not responding. While surgery is great for endometriosis, it should not be used just alone. So, anytime you have an endometriosis surgery, you do want to combine it or pair it with a good medical management long-term plan. High risk, for retreatment rates. So some of the data that, the studies, when you pull them together, for example, patients who at some point, if they undergo hysterectomy for endometriosis, it makes sense that the more organs you remove, the less likely you're going to have, problems develop long-term. And that's like a 3 to 5% risk of having to go back in for another repeat surgery. So it's pretty low with the more definitive surgery. Obviously, our younger patients where fertility is front and center and very important, hysterectomy is not a good option for them. And so you want to do what we call kind of uterine sparing procedures where you're going in to clean up the endometriosis, but you're leaving behind all of the reproductive organs. And it makes sense that there's a higher risk of reoperation after those type of procedures. Now, the goal after any of our endometriosis surgeries is that, you have a surgery, we get a good sense of what's going on, able to remove, the endometriosis and get you on a good medical management plan, and hopefully not have to revisit surgery again. But we know it is higher when there's uterine preservation. Pain reduction. So with laparoscopy, we know that we can get some good pain results. You know, when you go in surgically for endometriosis resection, it's much better than obviously just putting a scope in and taking a look. I just want to double check. Are you guys still able to see me okay?
Yes.
Okay, perfect. Sorry, everybody
Oh,
kind
I
of
don't see you at all.
from the
So
side.
that's weird.
Perfect. Okay, yeah, some of the
Sorry.
I couldn't see the normal face. Good. I just want to make sure we weren't being bombed or something. All right. So a combined approach with surgery and medical management. We want to define our goals for surgery and make sure that in that preoperative planning and that, you know, counseling and what our goals are for the surgery is so incredibly important. And again, each patient's surgical plan and goals is unique. So it's a good time for pictures and to kind of take a look and see what we're talking about with this disease process. So this upper left picture right here is just a good illustration, right? We talked about this very inflammatory disease process. We do know that there's different phases of the disease. When disease is no longer quote unquote active, it can kind of transition to what we call a fibrosis stage. Fibrosis is just another name for scarring. The tissue gets really tough. There's a very different tactile feedback when you're touching areas that used to have active endometriosis. And that scarring can kind of leave behind permanently change or permanently a difference in the appearance of those reproductive organs. When you see that with a nodule that's on the back of the uterus, you start to lose again some of those spaces that typically are supposed to be there. Things get kind of tucked up and changed a little bit. The bottom left is a lesion of macroscopic or deep infiltrative endo. There's that purple thing we talked about when you Google endometriosis. And then on the right lower hand side, it's important to note some of those atypical appearance of endometriosis. You're gonna miss it if you aren't looking close enough. But if you could see, there's this kind of blister area here towards the right, and that's called vesicular endometriosis, which is a subtype of peritoneal, right? We talked about that clear paint in a paint can and kind of gets flicked everywhere. And this is an incredibly really painful subtype because it just kind of coats in general your pelvic and reproductive organs and can be very, very painful. So peritoneal endo, another picture of those vesicular lesions. Again, we hate when we hear that patients have had surgery before. We're told they didn't have endometriosis because someone wasn't looking for the right areas and removing and knowing what they're looking for. Because again, if you don't know what you're looking for, you can miss this disease process. We talked a little bit about that fibrosis, that kind of whiter scarring of the tissue right at that bottom side of the screen. And then, you can tell that this patient has endometriosis. Just things are stuck. They're not quite in the correct anatomic location, and that's a big giveaway. This top, there's those kind of brownish areas called hemosiderin deposits. That's another sign of kind of some global general inflammation within the pelvis and endometriosis. Those lower areas of the slide are all peritoneal endometriosis, right? It's very subtle, but again, disease burden does not equal disease symptoms. Ovarian subtype, this is the second most common disease type. When you have this, this is one that you will pick up very, very readily with ultrasound. When you have, that can be very, very painful too. And when you go in to take out this endometriosis, it's important that you do take out that cyst wall because the recurrence can be pretty high unless it's managed and the cyst wall is taken out appropriately. It's going to prevent recurrence, help improve pregnancy rates. We talked about the ovaries and the quality of the eggs are dependent on that inflammation, and with the endometriosis right on the ovary, that needs to be taken care of. And they can get quite big. You can see the ovary on this bottom picture is bigger than the size of the uterus, and that's just incredibly painful for patients. And then deep infiltrative endometriosis. Surgery, there tends to be some pretty good, what we call bang for your buck with surgery as far as disease improvement. Think about areas that kind of start to invade past certain layers of the tissue. It gets harder for medical management to work in these locations. And so if you're able to do good resection in these kind of purple areas here and restore that tissue to normal, the hope is that when you go back on a type of medical management or disease suppression, that it's now able to work much better. And this is just some examples too. That top left picture, again, there's this nodule where, because of the inflammation, the neighboring organ or the rectum sort of gets pulled up and starts to touch the uterus. And that can be a reason why bowel movements are painful. Intercourse is painful. Again, you're losing your natural spaces there. And this bottom right picture shows that the adhesions, right, things that develop because of endometriosis, pulls the uterus over towards the left, and that pulling or that tugging or that distortion is again another reason for pain or discomfort. And then looking at this patient's fallopian tube right here, again, with all the endometriosis, the normal look of this fallopian tube is completely gone and it's completely damaged. So you can understand why in pretty severe cases, there can be some permanent or irreversible damage to the reproductive organs. Real briefly, I'll kind of touch on the staging classification. Staging really is a way for clinicians or physicians to describe what the pelvis looks like and how and what potentially there's surgical ramifications or fertility ramifications for it. It does not have impact. Your stage does not impact your symptoms. I think of
I don't have Laura anymore.
I don't have Laura either.
I do not either. I'm sending her text to see what happened. Otherwise, can you all see my screen now?
Yes.
Okay, all right. Okay, so I'm just going to continue in the interest of time. So in general, there, is deep infiltrative endometriosis. This is where the endometriosis actually infiltrates into the tissue more than 5 millimeters. This oftentimes does correlate with pain. And so, like Laura already discussed, it can obliterate the, natural spaces. And so that causes pain with bowel movements and pain with intercourse. And then what I believe she was going over at the time, that what she was probably about to say is that in general, this scoring system that was put out by the essentially our reproductive and infertility society, essentially correlates with fertility outcomes and, kind of the amount of disease burden you have, but it by no way correlates with the amount of pain that somebody has. So we oftentimes will do surgery on someone who has no pain for something completely unrelated, and then we see that they have essentially stage 4, which is the highest grade endometriosis there is. So it actually happens that my part was going to begin right after that. So it was perfect timing regardless. So the question is that, we do a lot of surgery, but we also see a lot of patients who have had surgery and their pain persists even after they have, a hysterectomy, which is removal of the uterus altogether. And so what do we do for patients once they've already kind of exhausted surgical management? So in a lot of cases, most people might not have only one, kind of disease process. And I did see that some of the questions in the chat were talking about, how, autoimmune diseases or immunosuppression can be related to endometriosis. And, we can get into that in a little bit. But in general, there are a lot of non-gynecologic causes of chronic pelvic pain. And some of them we know are associated with endometriosis. And those include things like irritable bowel syndrome, interstitial cystitis, painful bladder syndrome, recurrent urinary tract infections, fibromyalgia, depression, anxiety, and then musculoskeletal dysfunction. And the reason that I highlight musculoskeletal dysfunction is that multiple studies have shown that when your pelvic floor muscles are spasming, whether it is due to, trauma or endometriosis, your pain will unfortunately continue even after we take away the offending agent. And so really the key at that point is that we have to, continue you on hormonal suppression for the endometriosis, but we also have to kind of think of other therapies. And so, kind of in general, so when patients have been in pain for a very long time, their body starts becoming sensitized. And so we notice that they have pain in other areas as well. And that's called central nervous sensitization. And then they also have muscle spasms that kind of, may start in the vaginal area, but then that pain can start spreading to their back, to their legs, and vice versa, because the body essentially has to compensate for weaknesses in other areas. And so a lot of my patients who, come with a history of endometriosis, if we have already, completed hormonal management and surgical management, and they are still, having pain, we oftentimes will, refer them to pelvic floor physical therapy. And that is essentially a physical therapist who will do manipulations of, the lower back, the hips, and the pelvis, but then also do internal vaginal therapy to help relax some of those muscles. And then there are other therapies also that we oftentimes will prescribe, and those include usage of dilators, which is kind of pictured below, but then also vaginal muscle relaxants like Valium, Baclofen, systemic muscle relaxants, and then we can also complete injections into the pelvic floor muscles and complete pudendal nerve blocks. And then other therapies that help include, things that patients don't necessarily need a prescription for. And those include things like yoga, acupuncture, massage, cognitive behavioral therapy, because even though, endometriosis is a disease that we can see and we can treat, it doesn't mean that it doesn't cause a lot of stress, depression, anxiety. And we know that those things in turn can also contribute to pain. And then, of course, there are antidepressant medications that can help with both pain and mood. There are medications for pain sensitivity, and there are medications that help with bowel symptoms. So some of those are kind of over-the-counter supplements, but then we can also, treat things using medications that are typically used for like reflux disease and, bowel spasms and increasing fiber so that if you do have constipation, then it doesn't increase the weight and the pain on the pelvic floor. So in general, we're nearing the end of our presentation, and hopefully it's clear that endometriosis is very, very complex, and there is not one therapy that fits everybody. And so it's a very kind of individualized plan. And, we have to take a lot of things into consideration, other medical problems, where a patient is in their reproductive life, whether they, desire fertility, whether they do not desire fertility. All of these, contribute to kind of their plan of care. And in general, it is okay to start with medical management. We do not necessarily have to jump to surgery for everybody, but sometimes surgery is indicated. And then endometriosis is associated with a lot of other pain conditions. And so we need to treat individuals as a whole and kind of do multimodal treatment to, essentially address all of the concerns. And then kind of one kind of good thing or something to look forward to is that after menopause, pain related to endometriosis typically should decrease. That is why some of those really strong medications cause the pain related to endometriosis to decrease, because they put you into temporary menopause. So after menopause, the lesions should naturally start to just kind of regress on their own. They might not completely disappear, but they should become smaller and less bothersome. Now, the one thing we wanted to touch on, just, fairly quickly, so is PCOS, or polycystic ovarian syndrome. Now, in general, PCOS is not associated with endometriosis. They are very different entities. They can both be associated with heavy periods, but whereas endometriosis, you oftentimes will have periods more often. With PCOS, a lot of times women will skip periods and then just have really heavy bleeding every few months. And PCOS doesn't typically cause chronic pelvic pain. Now, your ovaries can be larger because you have multiple small follicles, which are essentially the precursor cysts to the eggs that we form every month. But in general, that can make it a little bit uncomfortable because your ovaries are larger, but it shouldn't cause a degree of pain that usually is associated with endometriosis. The good news is that they are both can be treated with hormonal medications because polycystic ovarian syndrome is really, it's a hormonal and a metabolic syndrome. But in general, we do not treat PCOS with surgery. If there's a lot of interest on this topic, we are of course happy to give another talk in the future, but it's with only 40 minutes, it's pretty hard to cover two really important disease processes. Okay. Do we have